The cervical spine allows for both support of the head and for movements of the head. With evidence of injury above the clavicles or in any comatose patient, the examiner must rule out a cervical spine injury before moving the patient. In the older population, degenerative cervical disc disease and degenerative arthritis of the cervical spine prompt many patients to seek medical attention. Because the cervical spine is intimately related to the peripheral nerves of the upper extremities, symptoms may be referred to the upper extremity or chest wall, and a detailed neurological examination of the upper extremities is an integral part of the examination of the cervical spine. Inspection. Note the posture and attitude of the head and neck region. Normally the patient holds his head erect and the neck moves freely. Any splinting or tilting of the neck may signify pathology. In contrast to the normal patient, note how this patient with ankylosing spondylitis lacks freedom of motion and must turn his body when attempting to turn his neck. The patient should be undressed to the waist and the neck region closely inspected for any swelling, scars, or other abnormalities. Note the symmetry when looking from the front and from the back. Note also from the side the normal lordosis of the cervical spine. Palpation. Cartilaginous and bony landmarks. With the patient lying supine, the neck muscles are relaxed, and the cartilaginous and bony landmarks anteriorly can be more easily identified. Thyroid cartilage. The superior aspect of the thyroid cartilage is usually visible and is commonly referred to as the Adam's apple. The superior margin of the thyroid cartilage lies anterior to C4 and the inferior margin at the level of C5. Hyoid bone. Superior to the thyroid cartilage, localize the hyoid bone between the thumb and the index finger. Note the mobility of the hyoid bone and also the thyroid cartilage when the patient swallows. The hyoid bone lies at the level of C3. First cricoid ring. The first cricoid ring of the trachea can be located immediately inferior to the thyroid cartilage and lies anterior to the body of C6. The ability to identify these anterior landmarks is extremely important in performing tracheostomies or cricothyroidotomies. Spinous processes. In the midline posteriorly, palpate the spinous processes from C2 to T1. Note any tenderness to palpation or any shift of a spinous process away from the midline. Inion. Superiorly in the midline of the occiput, localize the prominence or inion, commonly referred to as the bump of knowledge. Palpation. Soft tissues. Sternocleidomastoid muscle. This muscle is easily identified by asking the patient to turn the head to the opposite side against the resistance of the examiner's hand. The sternocleidomastoid muscle stands out near its attachment at the sternoclavicular joint region and can be followed upwards to its attachment into the mastoid process behind the ear. Examine each muscle in turn, noting any localized swelling or areas of tenderness. Lymph nodes. Carefully palpate along the anterior medial border of the sternocleidomastoid muscle to detect any enlargement of lymph nodes in this region. Also palpate the region of the supraclavicular fossa bilaterally, noting any swelling or enlargement of lymph nodes in that region which under normal circumstances are not palpable. Carotid artery. Anterior to the mid-portion of the sternocleidomastoid muscle, localize the carotid artery. Palpate each pulse separately, noting the volume. The carotid artery should be auscultated to detect the presence of any bruits. Trapezius muscle. With the patient sitting and the examiner standing behind the patient, identify the lateral borders of the trapezius muscle. They can be easily located by asking the patient to shrug the shoulders while applying resistance over the acromions bilaterally. Palpate the trapezius muscle inferiorly to its attachment on the clavicle, acromion, and spine of the scapula. Follow the trapezius muscle superiorly to its attachment at the posterior aspect of the occiput. Lymph nodes. Under pathological conditions, lymph nodes may be palpable along the anterolateral border of the trapezius muscle, and this region should be carefully palpated. Greater occipital nerves. Identify the inion or posterior prominence of the occiput in the midline and probe laterally along the base of the skull. Tenderness elicited in this region may suggest inflammation of the greater occipital nerves. Range of motion. Active. The cervical spine has a wide range of motion consisting of basically flexion, extension, rotation, and lateral bending. Combinations of these ranges impart a wide versatility of motion to the cervical spine. The majority of flexion extension takes place at the occiput C1 level, and the majority of rotation takes place around the odontoid at the C1-2 or atlas axis level. This can easily be recalled by remembering that saying yes is a higher function than saying no. Flexion. The patient is instructed to bend his head forward and should be able to touch the chin to the anterior chest wall. Extension. The patient is instructed to bend his neck backwards, as in looking up at the ceiling. Normally the patient should be able to look straight up at the ceiling, and thus the face is essentially parallel to the floor. Flexion and extension are best observed from the side, and as well as the range of motion, the smoothness or rhythm of motion should be noted by the examiner. Rotation. Instruct the patient to turn the head to the side, and under normal circumstances, the chin should almost be in line with the shoulder. Test rotation to one side from the neutral position, then to the other side. Lateral bending. While observing from the front, instruct the patient to tilt the head to the side and attempt to touch the ear to the shoulder. Observe the range of tilt from the midline, and do not be fooled by a shoulder shrug that the patient will frequently do in order to approximate the shoulder to the ear. Range of motion. Passive. Before attempting passive range of motion, a brief explanation of what you are going to do will allow the patient to relax fully and cooperate with the examiner. Caution. 2 points of caution must be observed by the examiner when testing passive range of motion. In any case of trauma where cervical spine instability is potentially present, passive range of motion should not be performed. Never attempt to force the cervical spine when testing passive range of motion. If motion is restricted, there must be a reason, and an attempt to passively exceed that range may be hazardous. Flexion. Standing behind the patient, support the head with both hands and passively flex the neck anteriorly and return to the neutral position. Extension. Passively extend the neck, and normally the patient will be able to look directly up at the ceiling. Rotation. From the neutral position, rotate the head to one side and then the other, comparing the degree of rotation to each side. Lateral bending. Bend the head laterally towards one shoulder and then to the other, noting the degree of lateral bend on each side. Neurological examination. The neurological examination related to the cervical spine and the upper extremities includes a detailed sensory, motor, and reflex examination. Patient relaxation and cooperation is mandatory, and a careful explanation of what is happening will greatly assist in this regard. Sensory examination. The following points must be noted on sensory examination. During sensory examination, the examiner should explain to the patient precisely what is going to take place, and the patient should have the eyes closed. Each sensory dermatome must be individually examined and compared to the corresponding dermatome on the opposite side. The examiner must test the following sensory modalities: pinprick, blunt or dull touch, light touch, temperature, warm and cold, 2-point discrimination, which is especially important in the hand region, proprioception, and vibration sense. Note any deficiencies of sensory examination on a diagrammatic chart depicting the exact localization and area involved, so that comparison with subsequent examinations can be readily made. Motor examination. The examiner is reminded that the following points are essential components of a proper examination of the motor system. Examine each specific muscle or group of muscles when the individual muscle function cannot be isolated. Palpate the individual muscle or tendon if possible. Record the strength of the muscle or muscle groups being tested on the 0 to 5 rating scale. Always compare the strength of a muscle or muscle group to its counterpart on the opposite side. In this program, the muscles related to the cervical spine, the shoulder, and the elbow region will be tested. Motor testing for the hand and wrist is demonstrated in the video program on the physical examination of the hand and wrist. Cervical region: sternocleidomastoid, 11th cranial nerve or spinal accessory nerve. With the patient sitting, stabilize the thorax with one hand and instruct the patient to flex the neck while resisting with the palm of the other hand against the forehead. Then remove the hand from the thorax and carefully palpate the sternocleidomastoid muscle on each side. The sternocleidomastoid can be tested individually by instructing the patient to turn the head to one side against the resistance of the examiner's hand. Stabilize the opposite shoulder to prevent trunk rotation. The opposite sternocleidomastoid is seen to stand out and can be palpated by the examiner. Lateral bending and extension. The power of lateral bending and extension of the cervical spine should be assessed. Note that many muscles or groups of muscles are involved and they cannot be individually assessed and palpated. Lateral bending. Stand at the side of the patient and stabilize the ipsilateral shoulder. Instruct the patient to bend the neck laterally while applying resistance to the lateral aspect of the skull. Muscles involved in lateral bending include the scalenus anterior, medius, and posterior. Extension. Stand behind the patient and stabilize the posterior upper thorax. With the other hand over the occipital region of the skull, resist the patient's attempt to extend the cervical spine. The trapezius muscle as well as the posterior paravertebral muscles, including the splenius, the semispinalis, cervicus, and capitis, are functioning during the act of extension. Shoulder region. Scapular elevation. Trapezius, 11th cranial nerve or spinal accessory nerve. Stand behind the patient and place each hand laterally over each acromion. Instruct the patient to shrug the shoulders up towards the ears while applying downward pressure on the acromions. Since the shoulder shrug maneuver involves several muscle groups, a discrepancy in strength between the two sides may denote weakness of the levator scapulae, C3, 4, rhomboid major and minor, C5, as well as the trapezius muscle. Scapular retraction, rhomboid major, rhomboid minor, C5, dorsal scapular nerve. Stand in front of the patient and grasp each shoulder region with the thumbs anteriorly and the fingers posteriorly. Instruct the patient to force the shoulders backwards, as in assuming a position of attention, and attempt with your fingers to rotate the shoulders anteriorly and medially. This maneuver tests the retractors of the scapula, namely the rhomboids major and minor supplied by C5. Serratus anterior, C5, 6, 7, long thoracic nerve. To test the serratus anterior, instruct the patient to push against the wall with the arms in an extended position. Normally, the medial border of the scapula will remain flat against the posterior chest wall. But if the medial border protrudes away from the chest wall, this denotes weakness of the serratus anterior and is called winging of the scapula. Flexion. Primary flexors. Anterior deltoid, C5, 6, axillary nerve. Coracobrachialis, C5, 6, musculocutaneous nerve. Immobilize the scapula by placing one hand over the top of the acromion in such a position as to be able to palpate the anterior aspect of the deltoid muscle. With the other hand, grasp the anterior aspect of the distal humerus and with the elbow at 90 degrees, apply resistance as the patient is instructed to flex the shoulder. Extension. Primary extensors. Posterior deltoid, C5, 6, axillary nerve. Latissimus dorsi, teres major. Continue to stabilize the scapula by pressing downwards on the acromion. While applying resistance to the posterior aspect of the distal humerus, instruct the patient to push the arm backwards or into extension as you palpate the posterior aspect of the deltoid to assess the tone of the contracting muscle. Abduction. Primary abductors. Deltoid, mid-portion, C5-6 axillary nerve, supraspinatus C5-6 suprascapular nerve. Apply resistance to the lateral aspect of the distal humerus as the patient is instructed to bring the arm out to the side. Continue to stabilize the scapula by downward pressure on the acromion and palpate the mid-region of the deltoid muscle. Adduction. Primary adductors. Pectoralis major C5 to T1, latissimus dorsi C6 to C8. Apply resistance to the medial aspect of the elbow region as the patient attempts to force the arm into the side of the body. While maintaining stability of the scapula, the examiner can palpate the pectoralis muscle anteriorly. Internal rotation. Primary internal rotator, subscapularis muscle, C5-6 subscapular nerves. With one hand, stabilize the elbow at the patient's side and with the elbow flexed to 90 degrees and the forearm in mid-pronation supination, apply resistance to the distal volar forearm as the patient attempts to bring the forearm across the front of the abdomen. External rotation. Primary external rotators. Infraspinatus C5-6 suprascapular nerve, teres minor C5 axillary nerve. Maintaining the patient's arm in the same neutral position, apply resistance to the dorsal aspect of the distal forearm as the patient attempts to turn the forearm away from the body. The power of all of the muscles or groups of muscles should be recorded, and comparison with the contralateral shoulder is imperative. Elbow region. Flexion. Primary flexors, brachialis C5-6, biceps C5-6, musculocutaneous nerve. Secondary flexors, brachioradialis, supinator. In order to test elbow flexion, the forearm should be in the supinated position. With one hand, stabilize the lower end of the humerus posteriorly, and with the other hand, apply resistance to the volar aspect of the wrist region. Instruct the patient to flex the elbow against resistance. Compare the muscle grade with flexion of the opposite elbow. Extension. Primary extensor, triceps, C6 to C8, radial nerve. Secondary extensor, anconeus. Maintain the same position as when testing flexion, but this time apply resistance to the dorsal aspect of the wrist region while instructing the patient to extend the elbow. Compare the strength to the opposite elbow and record the value on the muscle grading chart. Supination. Primary supinators. Biceps C5-6 musculocutaneous nerve. Supinator C6 radial nerve. Secondary supinator brachioradialis. Stabilize the distal humerus posteriorly and maintain the elbow at the patient's side to prevent any shoulder motion which may be used to substitute for supination. With the forearm in the pronated position, grasp the distal forearm with your other hand, and while applying resistance over the dorsal aspect of the distal radius, instruct the patient to supinate the forearm. Pronation. Primary pronators. Pronator teres, C6-7 median nerve. Pronator quadratus, C8 to T1 median nerve. Secondary pronator, flexor carpi radialis. Again, stabilize the elbow at the patient's side and grasp the distal forearm in a manner to apply resistance along the volar aspect of the distal radius. Instruct the patient to begin to pronate the forearm from the supinated position while applying resistance to the distal volar aspect of the radius. Pronation and supination can also be tested by grasping the patient's hand and applying resistance to pronation or supination through the hand. The examiner is cautioned, however, that pathology in either the hand or the wrist region could interfere with the results by diminishing the value of the muscle grading obtained. Deep tendon reflexes. Biceps C5, brachioradialis C6, triceps C7. Biceps reflex C5. Rest the patient's forearm across your forearm and palpate the biceps tendon in the antecubital fossa with your thumb. The biceps tendon can be easily located by asking the patient to flex the elbow. After locating the biceps tendon, however, assure that the patient's arm is completely relaxed before attempting to elicit the reflex. Strike your own thumb over the biceps tendon with the reflex hammer, and in the normal patient, the biceps muscle will jerk. This movement of the biceps can usually be seen in the thin patient, but with a more obese patient, the presence of the jerk will be appreciated by your thumb on the biceps tendon. As discussed in the neurological examination of the lower extremities, an increased deep tendon reflex suggests loss of inhibitory function of the brain or an upper motor neuron lesion. A decreased or absent deep tendon reflex suggests pathology in the reflex arc or a lower motor neuron lesion. Brachioradialis reflex C6. Support the patient's forearm across your forearm and tap the brachioradialis tendon over the distal aspect of the radius. A positive response is noted by a jerk in the brachioradialis muscle. Triceps reflex C7. Support the patient's forearm in a relaxed fashion across your forearm, and with the reflex hammer, tap the triceps tendon just proximal to its insertion into the olecranon. In the normal patient, you will be able to see the contraction of the triceps muscle or feel the extension jerk of the patient's forearm. The detailed neurological examination of the hand and wrist region is described in the video program on the hand and wrist. In order to document a complete neurological examination of the upper extremities, the neurological examination of the hand and wrist region would also normally be performed at this time. Special tests related to the cervical spine. Distraction test, compression test, Valsalva maneuver test, Adson test. Distraction test. Cervical traction is a common therapeutic modality used in patients with cervical pain and radicular symptoms. The physician can assess a patient's response to this form of treatment by performing the cervical distraction test. With the patient sitting and the neck in the neutral position, gently grasp the patient's jaw with the palms while the thumbs support the occipital region. Apply straight upwards traction and ask the patient if the pain pattern has altered. Note that relief of pain suggests that cervical traction may be a beneficial therapeutic modality. Compression test. Compression of the cervical spine can increase pressure on the facet joints and also decrease the size of the neural foramen. Hence, cervical compression can aggravate symptoms arising from these areas. With the patient sitting and the head and neck in the neutral position, place the palms on the vertex of the skull and apply gradual downward pressure. Note any increase in discomfort and also the exact distribution of any radiation of pain or paresthesias. Caution. The examiner is cautioned, however, that distraction and compression tests should not be performed on any patient with cervical trauma, and a compression test should not be performed on a patient with a suspected cervical disc protrusion. Valsalva maneuver test. The Valsalva maneuver increases intrathecal pressure. Instruct the patient to take a deep breath and then attempt to expire against the closed glottis, or to force as if they were having a bowel movement. Production of pain in the cervical region or radiation of pain into the upper extremities suggests the possibility of a space-occupying lesion, such as a disc herniation or tumor in the cervical canal. Adson test. The Adson test is performed in order to determine any compromise of the subclavian artery in the cervical region. A cervical rib or compression by the scalenus anterior and scalenus medius muscles may decrease the patency of the subclavian artery. With the patient standing, assess the volume of the radial pulse at the wrist. Gradually abduct and extend and externally rotate the arm. Then instruct the patient to take a deep breath and turn the head towards the side you are examining. A decrease in the radial pulse volume or obliteration of the radial pulse suggests compression of the subclavian artery in the cervical region. This concludes the examination of the cervical spine, but the examiner is reminded that the examination of the shoulder region and upper extremities, as well as the neurological examination of the trunk and lower extremities, must be performed if cervical pathology is detected.